Hello, my name is Madison Berbenda, and I will be discussing the pathology behind preeclampsia pregnancy. Thank you for taking the time to watch my presentation, and I hope you enjoy. Preeclampsia is a pregnancy-specific disorder that affects about 5 to 8% of pregnancies worldwide and accounts for about 70,000 maternal deaths, or 1 in 100,000 live births, and 500,000 fetal deaths every year. In the United States, preeclampsia is the leading cause of maternal morbidity and mortality, cesarean sections, and fetal prematurity. The prevalence of preeclampsia is higher in areas of low socioeconomic class and high prevalences of cardiovascular disease and disproportionately affects more non-Hispanic Black, American Indian, and Alaskan Native women. In addition to high rates of mortality, preeclampsia contributes to an increased risk of developing cardiovascular, renal, or neurological disease later in life. According to a study in 2017, within the first 12 months following delivery, the United States spends about $2.18 billion healthcare dollars on preeclampsia every year, with about $1.03 billion spent on mothers and the remaining $1.15 billion on infants. The amount spent every year rises as the prevalence of preeclampsia continues to climb as well. The pathogenesis of preeclampsia is complex and multifaceted. Three main complexes, endothelial cells, the renin-angiotensin-aldosterone system, or ROS, and angiogenic proteins are thought to be involved in the development of this disorder. The placental tissue is the key contributing factor to this disease process, and injury and dysfunction within the placental endothelial cells is a hallmark. Damage to endothelial cells can be caused by placental ischemia due to incomplete spiral artery remodeling and abnormal placentation. When endothelial cells become injured, there is a greater production of leukocytes and substances that promote coagulation and sensitivity to vasopressors, and a reduction in nitric oxide production. This combination contributes to increased vasoactive effects such as greater interstitial permeability, more substances in the blood that promote endothelial activation, and vasospasms. In addition to dysfunction in endothelial cells, multiple studies suggest that an enhanced RAS system contributes to preeclampsia. In preeclampsia, there is greater sensitivity to angiotensin II, which causes an increase in vasoconstriction, more endothelial cell damage, hypercoagulation, and reduction in trophoblast invasion. The increased sensitivity to angiotensin II in comparison to normal pregnancy is thought to be a result of the presence of autoantibodies to angiotensin II type 1 receptors due to placental ischemia and inflammation. Finally, angiogenic proteins play into the development of preeclampsia. Angiogenic proteins, vascular endothelial growth factor, or VEGF, and platelet growth factor, or PGF, are reduced in preeclampsia due to a greater amount of SFLT1, a receptor for these two proteins. Reduced amounts of these two angiogenic proteins causes, again, endothelial cell dysfunction, leading to greater progression of the disease process. One or combination of these factors lends to the pathogenesis of preeclampsia. The clinical manifestations of preeclampsia are dependent on the disease progression. Symptoms may appear and progress over a few weeks or within hours, and multiple organ and body systems are involved. The development of more symptoms is indicative of a more severe form of preeclampsia. While some symptoms may not be present, all women with preeclampsia have hypertension, which is also typically the first clinical indicator of preeclampsia. Additionally, cardiovascular manifestations may include peripheral or pulmonary edema due to increased capillary leakage and fluid shifts. The renal system is also involved in preeclampsia, and manifestations of involvement include proteinuria, increased serum creatinine, and oliguria. Preeclampsia is the most common cause of proteinuria in pregnancy, and a protein creatinine urine ratio of greater than 0.3 milligrams is significant. Third, hepatic involvement in preeclampsia is evident through elevated liver enzymes and right upper quadrant pain or epigastric pain. To be marked as significant, liver enzymes must be twice a patient's normal. To continue, the hematological system manifestations of preeclampsia are increased hematocrit, hemoglobin, and platelets. Thrombocytopenia is the most common coagulation disorder in pregnancy, so being aware of a patient's pregnancy normal is important. If platelets reach 100,000 or less, this is categorized as a severe range. Additionally, the neurological system is involved, which includes a headache and visual disturbances. Patients that develop a headache due to preeclampsia usually describe it as throbbing or pounding. Finally, the fetus can be affected significantly by preeclampsia, and manifestations such as intrauterine growth restrictions, reduced amniotic fluid index, non-reactive stress tests, or placental abruption could result. All of these clinical manifestations are important, and if at any point additional symptoms arise or become worse, it is important to take action and recognize that the disease process is progressing. As I mentioned previously, preeclampsia can develop over a couple months or weeks or shortly in just a couple of days or hours. For this reason, as healthcare providers, is it important to be vigilant of any changes in our patient's condition during the prenatal and antenatal periods. During prenatal visits, if a patient were to develop proteinuria in the second half of pregnancy without hypertension, a blood pressure that was 30 systolically or 15 diastolically above their baseline, or a fetal growth restriction, we should be aware that these could be indicators of early preeclampsia. To officially diagnose preeclampsia, certain manifestations need to be present. Additionally, in diagnosis, a patient can be diagnosed with preeclampsia without severe features or with severe features. The American College of Obstetricians and Gynecologists defines preeclampsia without severe features as new onset hypertension, which is greater or equal to 140/90 with proteinuria, or hypertension without proteinuria and at least one other symptom, such as thrombocytopenia, elevated liver enzymes, renal insufficiency evident through lab work, pulmonary edema, or new onset visual or cerebral disturbances. ACOG describes that the diagnosis of preeclampsia elevates to include severe features when a blood pressure greater or equal to 160/110 is measured twice, at least 15 minutes apart, or any of the already mentioned symptoms arise. A diagnosis of preeclampsia prior to 34 weeks is marked with the chance of greater adverse outcomes. The development of preeclampsia is unpredictable. While some clinical indicators may give rise to the beginning of preeclampsia development, such as a higher than normal blood pressure or proteinuria, as I mentioned before, often the onset of preeclampsia is random. Some risk factors, such as having metabolic syndrome, chronic hypertension, or preeclampsia in a previous pregnancy, place a woman at greater risk for developing preeclampsia. But often there is no predictability behind this disease process. Once preeclampsia is diagnosed, the gestation at onset as well as the severity aids in guiding the current recommendations for treatment. If preeclampsia without severe features is diagnosed prior to 37 weeks, expectant management is suggested by ACOG. During this period of expectant management, serial ultrasounds, weekly antepartum and laboratory testing, and close blood pressure monitoring takes place. If a woman is diagnosed with preeclampsia without severe features after 37 weeks gestation, delivery is recommended. In comparison, if preeclampsia with severe features is diagnosed prior to 24 weeks gestation, the current recommendation is termination of the pregnancy as maternal risk outweighs benefits this early. If preeclampsia with severe features is diagnosed between 24 and 34 weeks, expectant management also is recommended, most likely on an antepartum unit where maternal and fetal status can closely be monitored. During this time, 2 doses of corticosteroids can be administered to aid in fetal lung maturity. Finally, if preeclampsia with severe features is diagnosed after 34 weeks, delivery should take place. As I mentioned before, the disease progression of preeclampsia is complex, unpredictable, and severe. Understanding this and the pathology behind preeclampsia is important so that we can best care for our patients. At our patient's first prenatal visit, by identifying risk factors that place them at a higher chance of developing preeclampsia, we can be more in tune if symptoms were to present. Also, at every prenatal visit, if we take a close health and symptom management survey, we can hopefully make the diagnosis of preeclampsia early so that the proper recommended treatment is made. If risk factors are present or there are clinical indicators that preeclampsia may develop, and once the diagnosis of preeclampsia is made, close monitoring is important. Increasing prenatal visits, education on blood pressure measuring, and weight gain monitoring at home Prescribing oral blood pressure medications and taking baseline and serial lab work is all important to ensure that the disease is not progressing. If maternal or fetal condition is worsening, or if severe features are diagnosed, a referral to an OBGYN or maternal fetal medicine doctor may be necessary to ensure the most appropriate care is being provided to our patient and child. Finally, staying up to date on the current ACOG recommendations for treatment of preeclampsia is vital so we are providing the best care to our patients. Thank you all for watching, and I hope you learned a little bit more about preeclampsia. Have a great rest of your day.